Welcome to the Alfred Hospital Continuing Professional Development module in Managing Cardiac Arrest. In this video, we will cover some of the key components in managing an in-hospital cardiac arrest with high-quality resuscitation. The most recent guidelines were released by the Australian and New Zealand Committee on Resuscitation, or ACLS, in 2016. These guidelines continue to emphasise managing emergencies using a doctor's ABCD approach with rapid, effective cardiopulmonary resuscitation and early defibrillation of shockable rhythms. Early CPR is crucial for survival, with a 10% decrease in the probability of survival for every minute CPR is delayed. Basic life support is the preservation or restoration of life by establishing and maintaining an airway, breathing and circulation using the acronym Doctor's ABC. The following is a demonstration of basic life support. And Stuart! Stuart's not responsive. Can you please press the emergency button?
We're going to call for help now.
Yeah. The rescuer is opening the airway and looking, listening and feeling for breathing. Agonal gasping indicates poor cerebral perfusion. Stuart is unresponsive with abnormal breathing and CPR is commenced. The transition from assessment to commencing CPR should not take more than 10 seconds. CPR is the combination of chest compressions and rescue breathing. The aim of CPR is to maintain enough circulation to preserve cerebral blood flow until specialised treatment is available. Compressions should be delivered to the lower third of the sternum at a rate of 100 to 120 compressions per minute. Rescuers should minimise interruptions to compressions and push hard, aiming to compress 1/3 of the depth of the chest with each compression and allow for full recoil of the chest wall between compressions. It should ideally be performed on a flat, firm surface. Some hospital beds have a CPR lever, which immediately flattens the bed, which should be utilised. Compressions should be delivered to the lower third of the sternum at a rate of 100 to 120 compressions per minute. Rescuers should minimise interruptions to compressions and push hard, aiming to compress 1/3 of the depth of the chest with each compression and allow for full passive recoil of the chest wall between compressions. To maintain effective chest compressions, the person doing CPR should rotate every 2 minutes and not continue CPR beyond 5 minutes. Even effective CPR only delivers 25 to 33% of the patient's normal cardiac output and oxygen delivery. The role of a pulse check prior to starting CPR is controversial. It is reasonable to feel for a pulse if previously taught to do so as part of the assessment for signs of life, but the time taken to do so should be limited to 10 seconds. As this arrest is occurring in hospital, the advanced algorithm is now employed. Advanced life support adds defibrillation, advanced airway techniques, vascular access, and pharmacotherapy. During advanced life support, there is an emphasis on clear leadership, role allocation, and clear communication between team members. The leader facilitates the continuation of CPR with minimal interruption, relieves the first responder to allow for handover, and delegates important roles. The arrival of the defibrillator moves us forward in the algorithm and determines the electrical and pharmacological therapy required. CPR can continue whilst the pads are being attached. Shockable rhythms include ventricular fibrillation, discoordinated electrical activity not associated with a cardiac output, and pulseless ventricular tachycardia, a broad complex rhythm of rapid rate with a constant QRS morphology. It may be monomorphic or polymorphic. Non-shockable rhythms include pulseless electrical activity, which is organised electrical activity without adequate cardiac output, and asystole, an absence of electrical activity. Monitoring must be checked and ECG gain optimised to confirm asystole. Standard defibrillator pad placement is on the anterior chest at the right parasternal edge, over the second intercostal space, and in the axilla at the mid-axillary line over the sixth intercostal space. Alternatives include a biaxillary or anteroposterior configuration. Ensure good contact with the skin. The priorities during defibrillation are to minimise interruptions to CPR and deliver a shock of adequate energy to restore a perfusing rhythm whilst maintaining a safe environment. The resuscitation team will now demonstrate the safe operation of a defibrillator.
Compressions continue, oxygen away, everyone else stand clear. Charging. hands off. Top, middle, bottom clear. Rhythm check. Team leader, rhythm check.
It looks like we've agree. Yeah.
Happy to shock?
Yes.
Shocking. CPR, recommence CPR.
CPR is resumed immediately as the chance of developing a perfusing rhythm within the first minute of defibrillation is extremely small. The previous guidelines recommending 3 sequential shocks have been changed to delivering only a single shock for this reason. A precordial thump is an impact delivered with the ulnar aspect of a clenched fist from 20 centimetres above the patient's chest to the bottom third of the sternum with immediate retraction. It may be considered for patients with monitored pulseless VT if a defibrillator is not immediately available. It is ineffective for VF, and there is insufficient evidence at this stage for witnessed asystole caused by AV conduction disturbance. It should not be used for an unwitnessed cardiac arrest or for patients who have had a recent sternotomy or recent chest trauma. There is no evidence that establishing a definitive airway improves outcomes after cardiac arrest. However, there are advantages to inserting an endotracheal tube. It allows continuous chest compressions and continuous oxygenation and ventilation at 6 to 10 breaths per minute. It protects the airway from soiling. End-tidal CO2 also may guide management and decision making. It is a potential route of drug administration. Once ventilating through an endotracheal tube, you do not need to disconnect the oxygen source to defibrillate. CPR should be interrupted for a minimum, ideally not at all, to facilitate intubation. Presence of waveform capnography should be used to confirm placement. This will be present even if the patient has no perfusing rhythm. Drug administration can occur via IV, IO lines, or via the ETT. The timing for drug administration depends on the rhythm. Adrenaline has alpha and beta receptor agonist activity and improves myocardial perfusion. If the rhythm is non-shockable, 1 mg should be given immediately, then every second cycle, i.e. after every 4 minutes. If the rhythm is shockable, it is given after the second shock, then every second cycle. Amiodarone is used to enhance the likelihood of staying in a perfusing rhythm and is given if the patient is in a shockable rhythm after the third shock. Depending on the cause of the arrest, there may also be a role for calcium, magnesium, sodium bicarbonate, lignocaine, IV fluids, or thrombolysis. Once advanced resuscitation is underway, some attention should be devoted to the underlying cause of the patient's cardiac arrest. There may be clues in the history or procedure, and reversible causes of cardiac arrest should be addressed as soon as possible. Hypoxia can be avoided by ensuring a patent airway, supplying high-flow oxygen, and avoiding hyperventilation. Seeking evidence of fluid or blood loss, including inspecting surgical drains, controlling the hemorrhage, and resuscitating with IV fluid, will address hypovolemia. Electrolyte disturbance can be excluded by utilising point-of-care testing and checking recent lab results. Treat hyperkalemia with calcium chloride and insulin dextrose or a beta agonist, and replace any electrolyte deficiencies found. Hypothermia is rare in inpatients and may be treated with active rewarming or extracorporeal support. Hyperthermia may be due to overheating under surgical drapes, sepsis, or drug toxicity. Attention pneumothorax can be examined for clinically and potentially with ultrasound. The effect of toxins should be suspected in the setting of overdose, and examining the drug or anesthetic chart may assist with treatment. Tamponade will be discussed in future scenarios, and thrombolysis may be myocardial or pulmonary. Fibrinolytic therapy may be utilised, and CPR should be continued for a prolonged period following fibrinolysis. Establishing invasive monitoring early, if able to do so, can supply additional information to help guide the resuscitation. An arterial line may be used to take serial blood samples for analysis. The waveform negates the need for a pulse check, and a diastolic blood pressure of less than 20 mm of mercury may indicate inadequate CPR. The presence of waveform capnography confirms the position of the endotracheal tube in the airway. With continuous ventilation, pulmonary blood flow is the main determinant of end-tidal CO2. An end-tidal CO2 of greater than 10 mm of mercury may predict the return of spontaneous circulation. Using focused echocardiography in emergency life support, or FEAL, does not have an evidence base but is likely useful in experienced hands. It can be used to look for evidence of hypovolemia, tamponade, pneumothorax, thromboembolic events, and to confirm the cardiac rhythm. It is completed during the pulse check with a time limit of 10 seconds of scanning to minimise interruptions to CPR. In this scenario, the subcostal views are the ones most successfully obtained, and if cardiac structures are not visualised within 3 seconds, the procedure should be abandoned and reattempted during the next rhythm check. The decision to stop CPR can be challenging and should be decided as a team. It may be associated with a positive outcome, with the patient displaying signs of life and a return of spontaneous circulation. It also may be associated with recognition of futility, i.e. no ROSC after 20 minutes, and no reversible factors present. Other things to consider include the patient's pre-morbid physiological reserve, and a persistent end-tidal CO2 of less than 10 mm of mercury in intubated patients is associated with almost zero survival. If the patient is in VF, CPR should not be ceased until all reversible factors have been corrected. In addition to the H's and T's, there are particular situations where prolonged resuscitation is indicated. If the patient is hypothermic, they should be rewarmed while the resuscitation is ongoing. If asthmatic or in bronchospasm, correct dynamic hyperinflation by disconnecting the circuit and altering the ventilation strategy. In the situation of a toxicological arrest, the patient may need CPR for up to 4 hours. In an arrest after thrombolysis, the patient may need resuscitation for up to 90 minutes. In pregnancy, a perimodern caesarean section is indicated if in cardiac arrest for more than 4 minutes. In the case of prolonged resuscitation, mechanical chest compression devices or ECMO CPR may be available to assist the resuscitation team. Survival rates in patients suffering an in-hospital cardiac arrest range from 32 to 54%. Once return of spontaneous circulation has been achieved, the focus shifts to post-resuscitation cares. This involves ongoing management of the underlying cause of the arrest and end organ support. Maintenance of coronary and cerebral blood flow is achieved via supporting a mean arterial blood pressure above 65 mm of mercury. Investigating and treating an underlying cardiac or neurological abnormality, if suspected, will rule out coronary disease or seizure activity, and careful titration of oxygen therapy will protect end organs from damage due to hyperoxia. The Australian and New Zealand Committee on Resuscitation also recommends maintaining a targeted temperature of between 32 and 36 degrees Celsius for a 24-hour period for all adults with a cardiac arrest who remain unresponsive after return of spontaneous circulation. Beyond 24 hours, targeted temperature management is recommended in those adults who remain persistently comatose. This can be established by a rapid infusion of ice-cold intravenous fluid, up to 30 ml per kilo, followed by the use of cooling mats and ice packs, and should be commenced once in hospital. Successful resuscitation depends on the delivery of immediate, sustained and high-quality CPR, rapid defibrillation, and clear leadership and teamwork within a resuscitation team. A good leader displays situational awareness, clear and precise language, a hands-off approach, and encourages contributions from team members with active information exchange. The leader does not need to be the most senior doctor in the room. A junior member of staff may maintain leadership with active mentoring by a more senior colleague. There may also be situations where a different knowledge and experience caters to a shared leadership model. A good team member uses closed-loop communication, completes tasks efficiently, and communicates difficulties and uncertainties with tasks if and as they arise.